In my particular situation, I'm sporadic, and I was tested 2 years ago. So I'm just interested if I might actually be presenting as one of these new types, and there will be new types as we go along, I believe. So it's the frequency, 2 years, 4 years, 5 years. Is it just as your physician suggests to you?
We don't know if the next meeting we will have a new gene, but I think it's almost impracticable. We can't say that.
Okay,
but what we do is usually when we take the blood for the examination, we ask to the patient to be allowed to do research in that blood and to be allowed to communicate the results of the research, if any. So your blood has been examined, but it's not stopped at that level. It's a ongoing process.
Thank you.
Process.
Alan, you of course you can have a new gene, but I think what is important, and I wanted to ask if we can maybe somehow, this is just a suggestion, the biochemical phenotype as well as the localization of the tumor, to put a little bit up, in the genetic algorithm, because I very often see very nice, very sophisticated, very often almost correct genetic algorithms about, what kind of genes, we should look at. But I think that if we put a little bit up of the biochemical phenotype as well as localization of the tumor, it will not always, but very often lead us to what kind of gene we should test it. For example, in your situation, because you are my patient, and I can tell you, you don't secrete epinephrine. And if you don't secrete epinephrine, we already have some data about the MEX gene, and we know how the MEX gene actually behaves in terms of the biochemical phenotype. So there is no reason that we would do the MEX gene for you, because you ask, if I can have, some new gene. So I wanted to ask you if we can sometimes a little bit think a little bit more about the biochemical phenotype and the localization of the tumor, that maybe sometimes will help us a little bit stratify this patient for genetic testing a little bit earlier or quicker than we would wish, because those algorithms are very often correct, but sometimes are a little bit more complicated. For us, for the community here, maybe they may not be so complicated. But can you imagine if you have a practicing physician or somebody who is in the hospital and open it and they will tell you, oh my God, I'm completely confused, I don't know what to do. I have to call specialists.
Yes, I agree with you, Karen. Obviously, I think that one of the messages I tried to give a few years ago is that cancer is not very easy. It's a challenging. So you have to take in account all those things. So you can give the help you need from everything. So yeah. I agree with you. I don't like it to be too schematic, and this is the way. If yes, yes. If not, no.
Yeah, nothing is perfect. You always have.
We are not perfect at all.
You could also put biochemical phenotype as a clinical predictors.
Yeah.
I mean, but it's not easy just to have all the different possibilities. It's just in one. Yeah.
Oh yes.
Because it will help you.
Yeah, sure. You're right.
Neurofibromatosis cannot be without epinephrine. So it's impossible. So almost impossible.
Almost.
Okay.
So I disagree with the decision to have a fixed algorithm. The progress in sequencing, next generation sequencing, will make very easy and very cheap to do a complete panel of genes. With let's say we have seen a poster here with 500 pounds. Yes, money-wise, I believe that doing immunochemistry and a lot of other things is not much cheaper than doing in every patient with pheochromoparaganglioma disease a complete panel of the gene known thus far. And this makes probably also our patients more relaxed, because as you say, well, I have never seen patients with only norepinephrine producing with max gene. Well, but we are just starting. Maybe tomorrow we didn't see any patient with SDH mutation until a few months, a few years ago. So I think given that the cost of this procedure is going very, very low, I would suggest to do a generalized genetic screen, also considering the possible consequence for the relatives of our patients.
Yeah, well, I think that the hospitals are trying to save money.
Yes, but
And they will be saving money more and more because the economic situation is not doing well and will not do well. So the stepwise approach, I think it will be, perhaps, I am not sure, I am not hospital administrator, but I can tell you that a stepwise approach may be, I don't know, preferable. You know, in the future, you cannot test immediately everything because it will be still costly. Maybe the cost will be much less. I agree with you than was before, but still will be costly, and I'm not absolutely sure.
I just want to, I don't know what kind of mistakes can happen with next generation sequencing, but one concern I'd have, if you do the whole cluster, I'd be concerned that you start getting false positive results more often. And this is why in biochemistry it's better to keep the count to a minimum. And we've already seen quite a few false positive results in genetic testing by certified laboratories that have caused quite a lot of problems with patients who in the end do not have a mutation. This is certified laboratories. In whole families, 13 members of a family, genotype for SDHB mutations, and it's a false positive. So I'd be a little bit concerned about throwing the whole panel of tests to every patient with Pheo Researchers.
And you pay for chemicals, you pay for the manpower.
If I can say something, I want to make a little bit point, which is I understand the question of Maurizio, but also the answer of Gray. The problem is if we have two points. The first point is to make a sequence analysis to get a mutation. The second point is what to do with this mutation if there's a variant of unknown significance. And I think if I have to decide to build up a new lab and how to put the money, I will reserve half of the money to the discovery of the meaning of the mutation, because it's easy to get, but it's very hard to say, and sometimes we have to take some risk with the patient, so we are not sure 100%. So if going further with the numbers of SNPs and the variants, we will really complicate our life, but I know we should complicate it.
Thank you.
But this will be our main point.
Thank you, Dr. Opocher. Can I have one question?
Yeah, could I just make it very simple? If you have an adrenal pheochromocytoma, unilateral, and you're secreting epinephrine and norepinephrine equally, and how far would you go? And how far genetic testing would you go? And what would you test first?
I must be honest. I go to the end, up to the last possible investigation, and I think that most of the people work in this field, because we are people that make research also. So it's a little bit a different approach. If the message is for a laboratory which has the business doing analysis, maybe the message can be filtered by these algorithms. But I don't think that I think that other people is doing like me, is doing as much as possible. Obviously, we start from a particular point. We take in account everything, every possible predictor, but to be honest, I go as far as I can.